Okay, so you want to own a home healthcare agency. The idea sounds almost impossible to resist. America is getting older. Hospitals want shorter stays. Families want care at home. And every week, another patient needs a nurse, a therapist, or an aide to walk through the front door. Instead of sending them back to an institution, you do not need a giant hospital tower. You do not need an operating room, a surgical robot, or a building full of beds. From the outside, the business looks like a simple matching system. Hire caregivers, send them into homes, bill Medicare, Medicaid, insurance companies, or families, and let demographic demand do the rest. The problem is that a home healthcare agency does not get paid because care is needed. It gets paid because care is authorized, documented, coded, scheduled, delivered by qualified labor, and accepted by a payer after the work has already been done. That difference is the whole business. A home healthcare agency is not just a group of nurses driving around town. At the skilled end of the industry, it is a regulated clinical operation that turns physician orders, patient assessments, visit notes, therapy plans, billing codes, quality scores, and payer contracts into cash. At the personal care end, it is a labor marketplace wrapped in state licensing rules, Medicaid programs, private pay relationships, and constant scheduling risk. The visible product is help at home. The hidden product is proof. Proof that the patient qualifies. Proof that the visit happened. Proof that the service was skilled enough to be reimbursed. Proof that the plan of care was signed, followed, updated, and supervised. Proof that the aide arrived, the nurse assessed, the therapist documented, and the agency complied with rules that can change after the business has already built its cost structure. Demand is real. The Congressional Budget Office projects that the U.S. population age 65 or older will keep rising through 2036, growing faster than younger age groups. The Bureau of Labor Statistics projects employment of home health and personal care aides to grow 17% from 2024 to 2034, with hundreds of thousands of openings each year. Families prefer home. Hospitals need discharge capacity. Medicare Advantage plans, Medicaid agencies, and health systems all talk about moving care to lower-cost settings. From a distance, that looks like a tailwind strong enough to make every agency profitable. Inside the agency, the same tailwind becomes pressure. More patients mean more visits. More visits require more caregivers. More caregivers require recruiting, background checks, training, supervision, payroll, mileage, benefits, scheduling, quality control, and documentation review. A patient cannot be cared for by a demographic trend. Somebody has to show up at the house at 8:30 in the morning, know what to do, record it properly, and return tomorrow if the plan requires it. Before a single dollar arrives, permission comes first. If you want to operate a Medicare-certified home health agency, CMS does not treat the business like a simple local service company. A home health agency must provide skilled nursing or therapeutic services, maintain clinical records, operate under policies established by professionals, including physicians and registered nurses, supervise care through a physician or registered nurse, comply with state or local licensing laws, maintain a plan and budget, and meet federal health and safety requirements. That is the basic doorway. The real doorway is narrower. State licensing rules decide whether you can operate in a market at all. Some states require Certificate of Need approval, which means a new agency may have to prove that the community needs another provider before it can open. Accreditation surveys, Medicare enrollment, Medicaid enrollment, surety bonds, liability insurance, workers' compensation, background check systems, HIPAA compliance, emergency preparedness plans, and clinical quality programs all sit between the idea and the first patient. In May 2026, the doorway narrowed even further. CMS implemented a temporary, nationwide enrollment moratorium on new Medicare home health agencies and hospices, including certain non-exempt changes in majority ownership. The stated reason was fraud, waste, and abuse risk. For an owner, the policy sends a blunt message. Money alone does not guarantee entry. In some periods, buying into the industry may mean buying an existing certified platform instead of simply opening a new Medicare provider number. That changes the entry price. A non-medical personal care agency may be launched with a modest office software recruiting budget, insurance licensing work, and enough cash to cover early payroll. A Medicare-certified skilled home health agency is a different machine. The agency needs a clinical director, registered nurses, therapists, home health aides, intake staff, schedulers, billing people, coders, compliance review and electronic medical record system, medical supplies processes, referral relationships, quality reporting, and enough working capital to survive while payers process claims. The building can be small. The balance sheet cannot be careless. A realistic new skilled agency can consume several $100,000 before it stabilizes, and a more ambitious multi-branch platform can require millions. Much of that is not Marvel equipment or inventory, it is time. Payroll runs every week or every 2 weeks, while Medicare, Medicaid managed care plans and private insurers may pay later. Denials requests for documentation, prior authorization delays, and billing errors stretch the gap. When a patient visit happens on Monday, the worker expects to be paid on payday. The payer may not send cash until much later, if the claim is accepted at all. This is why financing matters even when the business does not look capital intensive. Debt can help an owner buy an existing agency, roll up smaller providers, or fund the payroll gap. Private equity can provide capital for acquisitions and back-office systems. A local owner may use a bank line of credit secured by receivables. Each option solves one problem and creates another. A line of credit can cover cash timing, but interest rises when working capital gets trapped in accounts receivable. Acquisition debt can buy scale, but it also forces the agency to produce predictable cash flow in a business where payers, labor markets, and regulators can all move against you. The revenue stack looks simple until the payer mix is separated. Traditional Medicare fee-for-service pays for qualifying skilled home health under a prospective payment system. In plain English, that means Medicare does not simply reimburse every minute at cost. It pays according to patient characteristics, clinical grouping, timing, functional impairment, comorbidity adjustments, and other rules under the patient-driven groupings model, often called PDGM. The patient must generally need part-time or intermittent skilled care and be homebound. The agency is being paid for a defined care period, not handed a blank check for every hour it wants to provide. Medicare Advantage creates the second layer. These plans receive fixed payments from CMS to cover enrolled beneficiaries, and then contract with providers. For the agency, that means the customer may look like a Medicare patient, but the economic counterparty is a private plan with its own authorization process, rate schedule, documentation demands, and network strategy. A plan can approve fewer visits, negotiate lower reimbursement, slow collections, or steer members toward preferred providers. Medicaid adds a third layer especially for personal care and home and community-based services. The state the managed Medicaid plan, or the local program, may pay for aides who help with bathing, dressing, meal preparation, mobility, and other daily living tasks. This revenue can be steadier in some markets, but rates are often politically constrained. Wage mandates, overtime rules, and staffing shortages can squeeze the gap between what the program pays and what labor costs. Private pay and commercial insurance add another layer. Families may pay directly for companionship assistance, extended shifts, or services not covered by Medicare. Commercial insurers may cover skilled visits, private duty nursing, or post-acute care under separate contracts. Workers' compensation hospital-at-home programs, health system partnerships, and value-based arrangements can add smaller streams. A strong agency rarely depends on one payer alone, because one payer can change the rules faster than an owner can rebuild the company. The cost machine starts with labor. In May 2025, BLS reported more than 4.3 million home health and personal care aides in the United States, with a mean wage of about $17.36 per hour and a median hourly wage of about $17.21. That number is only the base of the labor stack. Agencies also need registered nurses, physical therapists, occupational therapists, speech therapists, medical social workers, clinical supervisors, intake coordinators, schedulers, billers, coders, recruiters, quality staff, and managers. Add payroll taxes, overtime, travel time, mileage reimbursement, training, turnover, workers' compensation and benefits, and the visit cost can rise quickly. Then, the agency needs a system around the worker. The phone rings when a hospital wants to discharge a patient. Intake must verify coverage, accept or reject the referral, confirm a physician order, check staffing capacity, schedule the first visit, document the admission, assess the patient, build the plan of care, and begin the billing file. A nurse or therapist may see the patient in a home that is clean and organized, or in a home with stairs, pets, clutter, missing equipment, confused family members, or no one answering the door. The agency still has to make the visit productive, safe, and compliant. Revenue is only earned when the system catches all of that. A missed signature can delay payment. A weak note can trigger a denial. An unsupported code can create an overpayment demand. A late visit can damage quality scores and referral trust. The Office of Inspector General reported that CMS's 2023 home health improper payment error rate was 7.7%, or about $1.2 billion, and individual provider audits can force agencies to return money when documentation fails to support claims. The lesson is not that every agency is dishonest. The lesson is that the business operates in a high documentation environment where cash can be challenged after care is delivered. That is the central trap. The world needs more care at home, but the agency does not own the patient, the payer, the referral source, or the labor supply. It rents all four. The patient can choose another provider. The hospital can send referrals elsewhere. The caregiver can leave for a higher wage, a different schedule, or a less demanding job. The payer can lower rates, require authorization, deny claims, or delay cash. The agency sits in the middle, responsible for clinical quality and payroll certainty, while its revenue depends on other institutions approving the work. Traditional Medicare used to make that structure easier for many skilled agencies. MedPAC reported that in 2023, about 2.7 million fee-for-service Medicare beneficiaries received home health care, and Medicare spent $15.7 billion under the Home Health Prospective Payment System. MedPAC also reported that freestanding home health agencies had an average Medicare fee-for-service margin of 20.2% in 2023 and projected a 19% margin for 2025. Those margins help explain why investors pay attention to the sector. They also explain why policymakers pay attention. When regulators believe payments exceed costs, rate pressure follows. CMS estimated that Medicare payments to home health agencies in calendar year 2026 would fall 1.3% in aggregate compared with 2025, after payment updates, permanent and temporary adjustments, and outlier changes. MedPAC recommended that Congress reduce the 2025 base payment rate by 7% for 2026. Even if an agency performs well, its economics can be reshaped by a rulemaking process in Washington. The failure case becomes clearer when you look at Enhabit. Enhabit was not a tiny operator learning the industry from scratch. It had been part of Encompass Health, became an independent public company in 2022, and by the end of 2025 operated 249 home health locations and 117 hospice locations across 34 states. Its home health segment had an average daily census of 41,786 and generated $813.8 million in net service revenue in 2025. That is not a hobby business. That is a national platform with clinical infrastructure, referral relationships, public company reporting, and scale. Yet, the numbers still showed pressure. Enhabit's home health net service revenue declined from $850.1 million in 2023 to $824.8 million in 2024, and then to $813.8 million in 2025. Its payer mix moved in a way that explains the squeeze. Traditional Medicare represented 65.6% of home health revenue in 2023. 59.1% in 2024, and 55.9% in 2025. Medicare Advantage rose from 21.6% in 2023 to 31.1% in 2025. The company warned that Medicare Advantage plans typically negotiate directly with providers, shift administrative burden and financial risk, and pay materially less than traditional Medicare for comparable home health episodes. That is the trap in public company language. Patient demand can grow while revenue quality deteriorates. A referral may look attractive when a patient needs care, but if the payer authorizes fewer visits at a lower rate and takes longer to pay, the agency has to decide whether the volume is worth accepting. Turning away patients can hurt relationships. Accepting unprofitable volume can damage margins. At a local agency, that dilemma shows up in a scheduler's inbox. At a public company, It shows up in revenue mix adjusted EBITDA and strategic alternatives. In February 2026, Reuters reported that Inhabit agreed to be taken private by Kinderhook in a deal worth about $1.1 billion. Analysts describe the company as having experienced flat to down earnings for nearly 5 years, with reimbursement challenges and payer pressures. The story was not a dramatic collapse into bankruptcy. It was more subtle and more useful. Even a large, home-based care platform can be pulled between demographic demand and payer economics until public market investors lose patience. The success case has a different shape. The Pennant Group built a model around independent, local operating subsidiaries supported by a centralized service center for accounting, payroll, human resources, information technology, legal, risk management, and compliance oversight. By the end of 2025, Pennant operated 172 home health and hospice agencies and 63 senior living communities across multiple states. The structure matters because home health is local at the patient level and highly technical at the back office level. A nurse visit happens in one home in one town on one day. Billing compliance technology, recruiting systems, capital allocation, and acquisitions benefit from scale. In 2025, Pennant reported full-year revenue of $947.7 million, up 36.3% from the prior year. In its home health and hospice segment, management reported home health admissions growth of 44.1%, hospice average daily census growth of 28.6%, revenue growth of 41.0%, and segment-adjusted EBITDA growth of 37.8%. Adjusted EBITDA is a rough profit measure before interest, taxes, depreciation, and amortization, often used to compare operating performance, but it is not the same as cash left in an owner's pocket. Pennant's result does not mean the business is easy. It shows what has to go right. Scale can spread technology, billing, expertise, compliance, and recruiting systems across many agencies. Local leaders can build referral relationships with hospitals, physicians, senior communities, and case managers. A diversified footprint reduces the damage from one state rate cut or one market staffing problem. Acquisitions can add volume, but only if the operator integrates culture, systems, and quality without losing clinicians. The success is not magic. It is the combination of local trust and centralized discipline. Bargaining power still sits above the owner. Medicare Advantage is the cleanest example. KFF reported that in 2026, 55% of eligible Medicare beneficiaries were enrolled in Medicare Advantage, and that United Health Group and Humana together accounted for nearly half of Medicare Advantage enrollment nationwide. When payer concentration grows, a local agency may face a contract that is less like negotiation and more like a choice between accepting difficult terms or losing access to patients. The plan does not have to own the agency to influence the agency's economics. It only has to control enough covered lives. Referral sources have their own leverage. A hospital discharge planner wants the patient accepted quickly, seen promptly, and kept from bouncing back to the emergency room. If an agency misses visits, rejects too many cases, or creates family complaints, referrals can shift quietly to a competitor. A physician group wants clear communication. A family wants the same aid at the same time every week. The owner is constantly selling reliability in a business where staffing reliability is the hardest thing to produce. Now build a simple one-year owner model. Imagine you acquire a regional Medicare certified agency with a small personal care line. The model is illustrative, not a report from one company. In a normal year, the agency generates $3 million in net service revenue. Traditional Medicare skilled episodes contribute $1.35 million. Medicare Advantage and commercial managed care contribute $900,000. Medicaid personal care contributes $450,000. Private pay workers' compensation and smaller contracts contribute $300,000. At first glance, $3 million feels like a healthy local business. Direct clinical and aid labor absorbs about $1.65 million. That includes visit pay, hourly aid wages, payroll taxes, benefits, overtime, and some travel-related labor friction. Clinical supervision, intake scheduling, billing, coding, payroll, recruiting, and quality assurance cost another $650,000. Software, insurance, rent, phones, background checks, supplies, mileage reimbursement, training, professional fees, and marketing cost about $350,000. Denials, write-offs, and slow collections remove another $100,000. After those costs, the agency has around $250,000 of operating profit before owner, salary, taxes, major growth, investment, and acquisition debt. If you paid cash and run tightly, that can be a solid business. If you borrowed to buy it, the picture changes. A $1.5 million acquisition loan at a blended interest and principal burden of roughly $180,000 per year can leave only about $70,000 before taxes and reinvestment. One strong referral relationship or one good payer contract can make the year feel stable. One labor shock can make it feel fragile. The bad year does not need a disaster. Revenue falls 6% because a hospital partner slows referrals and a Medicare Advantage plan tightens authorizations. That reduces net service revenue by $180,000. At the same time, wages rise 5% because competing employers are paying more for aides and nurses. If direct labor was $1.65 million, that adds more than $80,000 of cost. Fixed back-office expenses do not fall much because the agency still needs schedulers, supervisors, software, billing, compliance, rent, and insurance. A normal year's $250,000 operating profit can shrink to almost nothing before debt service. With acquisition debt, the owner can move from a respectable return to negative cash flow without a scandal, recession, or collapse in demand. That is why the agency's biggest risk is not empty demand. It is mismatched timing and control. Care needs are continuous. Payment approval is conditional. Payroll is immediate. Regulation is complex. Labor is scarce. Referral relationships are fragile. A home healthcare agency can look asset light because it does not own a hospital, but it is not risk light. The assets are people, licenses, payer contracts, quality scores, patient records, and trust. Lose any one of them, and the business can shrink faster than its overhead. The future will not remove this tension. It will make the best operators more valuable and the weakest ones easier to expose. Value-based purchasing is one example. CMS expanded the home health value-based purchasing model nationwide, tying payment adjustments to quality and efficiency measures. The agency is no longer judged only by whether visits were delivered. Outcomes, patient experience, hospitalizations, functional improvement, and claims-based performance can influence future payment. In theory, that rewards the operators who keep people safely at home and reduce expensive institutional care. In practice, it also raises the cost of data, clinical coordination, training, and measurement. Artificial intelligence remote monitoring and scheduling software may help agencies route workers better, identify risks earlier, reduce missed visits, and prepare documentation more cleanly. None of that eliminates the human core. A blood pressure alert still needs a clinician's judgment. A fall risk still needs a person in the home. A confused patient still needs trust. Technology can improve the machine, but it cannot turn care into a purely digital product. Consolidation is the other force. Large platforms can spread compliance and technology costs, negotiate with payers from a stronger position, and buy smaller agencies that cannot manage reimbursement pressure. At the same time, antitrust regulators have shown interest in home health markets when major transactions threaten local competition. The industry is moving towards scale, but scale does not create unlimited permission. For the owner, the decision becomes more precise. This is not a business where the simple question is, how many patients can I get? The better question is, which patients can I serve safely, staff reliably document correctly, and get paid for at a rate that covers the real cost of care? A smaller agency that rejects bad contracts may survive better than a larger agency that accepts every referral. A larger platform with disciplined intake, strong clinical leadership, and careful payer negotiation may outperform a crowded market of undercapitalized competitors. None of this means a home healthcare agency is automatically a good or bad investment. The numbers change with state regulation, payer mix, labor markets, financing, acquisition price, quality scores, and new CMS rules. This is an explanation of the machine, not personalized financial, legal, tax accounting, or investment advice. The machine matters because the social need is not going away. Older Americans will keep needing help after surgery. Illness falls, chronic disease, and frailty, families will keep trying to avoid institutional care when home is possible. Hospitals will keep looking for safe discharge options. Payers will keep looking for lower-cost settings. The demand story is powerful, and that is exactly why the business attracts entrepreneurs, public companies, private equity, insurers, and regulators at the same time. You thought you were buying a simple agency that sends caregivers into homes. What you were really buying was a regulated labor documentation and reimbursement machine wedged between aging families' scarce clinicians' referral gatekeepers and payers that can change the economics after the visit is already done. That is the real economics of owning a home health care agency.